Hey guys, this is Dr. Lisa Shiver with part 5 of the lower GI system alterations. In this section we're going to talk about the liver disorders. First of all, we're going to mention hepatitis. A key point that is important to note is that hepatitis just means inflammation of the liver. And it can be due to several different things. It's not just viral hepatitis, although the viral hepatitis may be the more common type of hepatitis that we deal with. Other causes could be things like drugs, chemicals. When I say drugs, I'm talking about things like Tylenol or anything that can cause inflammation of the liver. It also could be an autoimmune disorder, meaning the body is attacking itself and it's caused inflammation of the liver. It also could be due to a bacteria. So again, the important thing to note is just because it's hepatitis, we tend to think hepatitis B or C. It could be something else that is not viral in nature. The viral hepatitis are the most common, and there is a hepatitis A, B, C, D, E. There is no F, and there is a G. Obviously, the ones we know the most about are going to be the A, B, and C. They've been around the longest. The D, the E, and the G aren't as common, and we don't know as much about those. To diagnose hepatitis, the viral hepatitis, we look at serum antigens and antibodies. An antigen is the virus itself. Is the virus present in the body? If it is present, that means that you have an acute infection. When we look at antibodies, this means has the body responded to the fact that the antigen is there. So when we make antibodies, it's our immune system's way of protecting ourselves. So if somebody has antibodies against hepatitis A, that would mean they have been exposed, but they may not be acutely ill. So in general, we're looking to see are there antigens and or antibodies present with the viral hepatitis. We're going to start with hepatitis A. Some key things to know about hepatitis A. It is acute in nature. There is no chronic state to hepatitis A. The course of hepatitis A can last up to several days, up to weeks. But again, once the patient has recovered from that, there is no long-term or chronic state for hepatitis A. It is transmitted through the fecal-oral route, so usually contaminated food, contaminated water. The nice thing about hepatitis A is there are preventative vaccines that are very effective. They are given IM, and you get a baseline booster, and then in 6 to 12 months you'll get a second booster. If the patient possibly is exposed to hepatitis A and they have not been vaccinated against it prior, we can give what's called a hepatitis A immune globulin. When we give an immune globulin, what we're actually giving the patient is antibodies against hepatitis A. So the body doesn't have time to build antibodies and protect itself, so what we're going to do is go ahead and give them the antibodies. With immune globulins, though, they are short-acting, so they are not permanent. Hepatitis B is our next hepatitis. This does cause a chronic hepatitis state. The incidence has decreased because of the hepatitis B vaccine that most of us are familiar with. We get a series of 3 shots over a 6-month period of time, and they are given in the muscle. 95% effective in most cases. The risk for hepatitis is increased with exposure to blood or body fluids that may contain blood. So an interesting little thing to note about hepatitis B is it can live outside the body up to 7 days, which is kind of scary. So it can live in dried blood that long. Thankfully, we have the preventative vaccines as healthcare providers that are 95% effective. If a patient has not been vaccinated against hepatitis B and are protected and yet they get exposed, well then, just like with the hepatitis A, there is a hepatitis B immune globulin, and it is, we give the patient hepatitis B antibodies, and this is in an emergency situation, and it will give them automatic protection against the hepatitis B virus. But again, those immune globulins aren't long-living, they're just short-term fix. Then there's hepatitis C. Hepatitis C also causes a chronic hepatitis condition, and we'll talk about the difference between an acute hepatitis and a chronic hepatitis in just a minute. But hepatitis C is the most common liver disease in the United States, probably for the fact that we do not have a preventative vaccine, and that's kind of scary. Hepatitis C can live outside the body for up to 4 days, or in dried blood up to 4 days. Your risk is increased with exposure to blood or body fluids. And what we do see is a lot of patients who are HIV positive also have a co-infection of hepatitis C. So it seems like hepatitis C and HIV, they like to hang out together. So it's not uncommon that if you have one that you have the other. It does not mean, though, everybody with hepatitis C has HIV and vice versa. Everyone with HIV has hepatitis C, so please don't get that confused. We just see a lot of folks who have co-infections of those two. With the hepatitis C, most of these patients do develop a chronic hepatitis state, and they are pretty sick. And again, scary that there is no preventative vaccine, especially for us. There are some other hepatitises that we don't see as much here in the United States, such as hepatitis D. It does cause a chronic hepatitis as well. The thing about it is D has to have hepatitis B to replicate, so you have to have hepatitis B to have hepatitis D. So the D needs the B to replicate or reproduce. D is spread through exposure to blood and body fluids as well. With hepatitis E, it causes more of an acute infection, meaning the patient might be very sick for a short period of time, but then once it's gone, it's gone. So when you study hepatitis E, also study hepatitis A, because they are very, very similar. They're both transmitted through the fecal-oral route, and they can make you pretty sick, but they both don't have any long-term permanent liver damage effects. There are very limited tests to detect hepatitis E, and we generally don't see it in the United States or North America. We see it in other populations with contaminated water or where they don't have water treatment plants generally. Hepatitis G is a chronic hepatitis. We don't know a whole lot about it, except we do know it is transmitted through blood or body fluids that contain blood. And this one likes to hang out with hepatitis C, so sometimes when there's a hepatitis C infection, we see G as a co-infection. I did skip F. There is no hepatitis F. We did think at some point there was, but then it turned out it was, we had just re-identified a strain that already existed. So there is no hepatitis F. Signs and symptoms with hepatitis, we can have acute or we can have chronic. With acute, you're going to see the malaise, which is weakness, fatigue. Patient just doesn't feel good, run down, nausea, vomiting, diarrhea, constipation, fever may occur. Dark urine may be present, and that could be due to bilirubin being spilled out into the urine. Jaundice may also occur. And some things you need to just keep in mind when a patient has jaundice. This is excessive bilirubin, of course, in the body. It's not uncommon that we see itching because the bilirubin is going to try to seep out through the patient's skin, and that can be very irritating to the skin. The best place to assess jaundice is, of course, look in the whites of the eyes or the sclera. You can also look at mucous membranes or the palate. Open the mouth and look at the palate. For pediatric patients, the best place might be the tip of the nose, and you can touch it and blanch it, but then look to see if the jaundice returns. Hepatomegaly means a big old enlarged liver, so we might be able to palpate an enlargement of the liver in the right upper quadrant. And they may have tenderness as well, because the liver's inflamed. With our chronic hepatitis, you can have all the symptoms of acute as well, but then there's more that comes with it. Some folks with chronic hepatitis are asymptomatic. They just have elevated liver function tests, and we'll talk about those in just a minute. LFT is liver function tests. Cirrhosis may occur. Cirrhosis is when the liver begins to scar, and that can happen due to many different things. So many things can cause cirrhosis, but cirrhosis is hardening or when the liver scars. Ascites Ascites is an accumulation of fluid in the abdominal cavity, and we'll talk more about it in just a minute. Bleeding can be an issue because think about what the liver does. It manages all our clotting factors, and if we are not able to make clotting factors, or we're not able to make vitamins, one that comes to mind is our vitamin K, well then we're going to be at risk for bleeding. Also, encephalopathy can occur, and that's one of the end stages of cirrhosis, which can lead to liver failure. And then of course patients with chronic hepatitis may have to receive a liver transplant. So chronic is all of the symptoms of acute potentially, but then the symptoms of course get more extreme. Complications with hepatitis, most will have none, surprisingly enough, especially the acute hepatitis patients. Again, I mentioned, especially with hepatitis A and E, they do have a period of time where they are really sick, but once that passes, their liver will be fine in most cases. For those who do have liver damage, we see anything from hepatic failure. They may develop the chronic hepatitis where they have ongoing signs and symptoms. Cirrhosis, which I mentioned a second ago, liver cancer or hepatocellular carcinoma may occur, and fibrosis. A big thing to keep in mind, how will the patient be affected? Well, it's going to depend. Do they have any other coexisting conditions such as a history of chronic alcohol use, obesity, and diabetes? When somebody has chronic alcohol use, obesity, and diabetes, those are not in their favor when we're talking about liver issues. All right, I mentioned just a minute ago the liver function test that you may see ordered. If you need some more detail on what these tests are telling you, of course, you can look in your drug book. I just want you to have a general understanding of what each one does. If you have an elevation in your AST, that could represent liver damage or disease. Same thing with the ALT. If your GGT is elevated, it could be liver or bile duct injury. Elevation in your alkaline phosphatase or your ALP may demonstrate liver damage, disease, or even bone breakdown. Now your alkaline phosphatase, that's the one that changes with bone changes as well. So it could be liver, but it also could be bone. When we look at albumin and total protein, if our levels are decreased, it could be liver damage as well, because remember your liver helps make proteins, the big one being albumin, and also may show signs of malnutrition if those are all decreased. Bilirubin may be elevated, again, suggesting liver damage and disease, and your PT, which is a clotting time, may indicate liver damage. So all of those grouped together are what we call the liver function test. Anytime there's something going on in the body and we see craziness with our liver function test, well then that's a good indicator that this could be liver related. A little hint for you, going back to the AST, I was always taught that alcohol, statins, which are your cholesterol medications, and Tylenol will cause your AST to be elevated. Of course, your other ones may be elevated too, but think about chronic alcohol use, your statin drugs, which can beat up a liver, and also Tylenol overdose will elevate an AST. So that'll help you remember some of the things that cause elevations in your liver function tests. To take care of a patient who has hepatitis, we're going to, of course, treat the symptoms. We mentioned some patients may not have any symptoms with hepatitis, but then some may have a lot of symptoms. So it's going to be supportive or symptomatic care. The big thing is if we can get the patient to rest. The liver is able to regenerate up to an extent, meaning the liver can help heal itself with adequate rest. We do still want the patient to, get up and ambulate some, but we need to provide rest, especially when the liver is inflamed. Activity is going to be as tolerated. Our diet is going to include increased carbs and protein. Protein is great for healing. We'd want to decrease fat because the liver is unable to produce fat-soluble vitamins we do want to decrease the fat intake in the diet. We also want to avoid alcohol. TPN may be required to help provide the patient with adequate nutrition. So we may have to give them all their nutrients through their vein. Something that's important for the nurse to keep in mind is any time we have a new diagnosis of hepatitis, of viral hepatitis, so A, B, C, D, E, or G, we must notify the state health department, and that's required by law. So anytime we have a patient with a new diagnosis of viral hepatitis, we will have to call the state health department, and they'll do a follow-up from there to see if there's anybody else that the patient may have exposed or been in contact with that needs to get tested. Teaching is very important with these patients, teaching them about diet, their activity, things of that nature. We'll talk about medications in just a minute. Also, a big thing is to avoid medications metabolized by the liver, and the biggest one I can think of that is the common drug that we use is Tylenol. Tylenol will beat up a liver. So if a patient already has liver issues, we need to avoid Tylenol-based products. When looking at the chronic hepatitis B drug therapy, there are two drugs that you need to remember, or at least be familiar with. First one being Epivir. If you notice, Epivir has VIR in it. Well, the VIR represents viral. Anytime you see a drug with VIR in it, there's a good chance that that is an antiviral drug, and that's exactly what this is. Epivir helps decrease the viral load, which means decrease the amount of hepatitis B that is being reproduced in the body, and it can decrease liver damage as well. Alpha interferons, or interferon A, is a type of interferon, obviously, but this one too also helps, it has antiviral properties. It's a glycoprotein that will decrease the amount of virus in the body as well. The biggest effects we see with alpha interferons is it decreases the long-term liver damage, so it's going to help decrease the amount of long-term effects. There are some signs and symptoms with alpha interferon, and it can be anything from flu-like symptoms, hair loss, and it can mess with your thyroid too. With our chronic hepatitis C and drug therapy, again, we're going to use alpha interferon, so that same thing we would use with B. It's going to help decrease the viral activity. And then we've got another antiviral here, Virazole. Please note the spelling in the generic name there. It is an antiviral. I see Vir present. It inhibits the viral replication of the hepatitis C virus. So it's going to help slow down that process. Please note that there is no cure for hepatitis B and hepatitis C. All we can do is slow down the reproduction of the virus itself. Now, we've talked about all the viral hepatitis, but we need to look at drug-induced hepatitis. Remember, hepatitis just means there's inflammation of the liver. Most commonly viral, but there can be other things that cause hepatitis, such as drugs. These drugs can be something we inhale, inject, ingest. Some examples, again, Tylenol will beat up a liver. Tylenol overdose will cause drug-induced hepatitis. Our gold compounds. We talked about gold compounds a couple weeks ago when we did rheumatoid arthritis and how that's used to decrease the amount of deformity. But too much gold compounds can be hard on the liver. Also, the statin drugs that we use for cholesterol are very hard on the liver. Of course, our elderly populations are going to be at higher risk because as we get older, our total liver function is going to decrease. Signs and symptoms are going to be the same as the chronic viral hepatitis, with the end result possibly being liver failure. To treat these patients, we need to remove whatever those drugs are. Give supportive care, meaning treat the symptoms, and if we have progressed to liver failure, then liver transplant would be our only option. There is also a disorder called autoimmune hepatitis. With this one, the immune system is attacking our liver. Our immune system is beating up our own tissue. When patients have autoimmune disorders, it's usually seen throughout the body. So they may already have something else like rheumatoid arthritis, or SLE stands for the systemic lupus erythematosus, or what we more commonly know as lupus. Signs and symptoms, again, same as chronic viral hepatitis, and it can progress to liver failure. So since this is immune driven, we want to slow down the immune response, or slow down the immune system. And we'll use steroids, which suppress inflammation. We may also use immunosuppressive agents, and these are the agents that slow the immune system. Liver transplant may be an option, but the issue is the immune system. So even if the patient does get a new liver, the immune system may still try to attack that tissue. So it may be a reoccurring issue. Now let's talk a little bit about cirrhosis. I mentioned earlier how cirrhosis is usually secondary to chronic disease. So several things can cause cirrhosis. Whatever caused it really is irrelevant. The end result is we have a fibrotic or a scarred liver that does not function. If we can detect cirrhosis early, if we can detect that there is liver damage occurring, it can be reversible. Remember, the liver can regenerate with rest. But if it's at the end stages, it cannot be reversed. Cirrhosis is commonly related to alcohol ingestion, and that's probably the most common thing that we see as a cause of cirrhosis, chronic alcohol ingestion. Can be drug or toxin related. Could be related to viral hepatitis, and I'm thinking B and C in particular, and it also can be autoimmune. So the causes can vary, but the problem is the liver has scarred. Signs and symptoms. Early on, we're going to see anorexia or dyspepsia, which means indigestion. We might have flatulence, nausea, vomiting, variation in bowel habits. Fever may occur. Patient's just going to be exhausted and have weight loss. Late with cirrhosis is where we start to see jaundice. We mentioned the best places to assess jaundice earlier. We'll start to see some big things like peripheral edema, and that's going to be related to the decreased amount of albumin, and we'll talk about that in just a second. Ascites will also develop. Ascites is the accumulation of fluid in the abdominal space. Pruritus is itchy, scratchy skin. That's the body trying to rid the waste through the skin, and it's going to cause itching and scratching of the skin. Portal hypertension is hypertension of the portal vein, and we'll talk more about it in just a minute. Ecchymosis is bruising, superficial bruising, and this is going to be secondary to coagulation deficits. And we also are going to have hepatomegaly, or an enlarged liver, which ultimately all this leads to encephalopathy. And we're going to break down each of those and talk about why they are occurring. We'll start with the portal hypertension. With portal hypertension, the pressure in the portal vein is increased. And just to give you a brief H&P review, the portal vein is the only vein in the body that carries oxygenated blood. And it takes the oxygenated blood to the liver. Well, if the liver has scarring and it's no longer working, well then there's a backflow, or the pressure in the portal vein is going to increase. The problem with portal hypertension is it causes systemic hypertension. It can cause ascites, and again, that's the fluid accumulation in the belly. Fluid starts shifting out of the vessel. It also can cause peripheral edema and varices, more commonly esophageal varices. To treat the patient, we would put them on a beta blocker like propranolol or Inderal. This will help decrease the pressure in the vessels, therefore decrease our risk for bleeding. With esophageal varices, these are enlarged dilated veins of the esophagus, and the problem with these, and I'll show you a picture here, this is a picture of an esophagus with esophageal varices, If we do things to irritate these or they rupture, the patient is at great risk for bleeding out. The treatment for esophageal varices involves balloon tamponade. We use a Blakemore tube that's inserted into the esophagus, and then it is dilated, and it uses compression to decompress or to stop the bleeding of these esophageal varices. Risk factors for esophageal varices, of course, you have to have liver issues and have the portal hypertension, but what could cause one of these to rupture? Chronic alcohol use, if they use aspirin or any blood thinners. Spicy foods could cause irritation and cause rupture. Also, coarse foods like crackers or something that's not chewed well could cause problems with esophageal varices. To reduce the amount of gastric acid, we use Tagamet. This will help inhibit the gastric acid secretion and help reduce the chance that one of those varices were to rupture. So there's several things we've got to consider when a patient has esophageal varices. And I remember being an ER nurse years ago, I've had a patient that came in and had a ruptured esophageal varices, and it was one of the messiest things I had ever seen. It was quite scary. Now let's talk a little bit about ascites. Ascites, I've mentioned, is accumulation of fluid in the peritoneal or the abdominal cavity. What causes ascites, though, can be confusing. If your liver is not working like it should, well, then it's not making albumin. Albumin is a protein that holds the volume in the vessel. So if we do not have albumin, our volume is going to leak outside the vessel and cause things like peripheral edema and also ascites. In addition to that, we've got portal hypertension. So we've got a combination of things here that's causing fluid to be pushed or to leak outside the vessel. When a patient does have ascites, it can be very uncomfortable for them. You must consider things like their respiratory status. It's important for us as the nurse to measure abdominal girth. So we would measure around the belly button or the umbilicus once a day. Also, don't forget about your daily weights. They're the best indicator of your fluid volume status. Diuretics would be used to help reduce the amount of fluid. They would definitely be on a sodium restriction because wherever there's salt, there's water. And to remove that fluid, for extreme cases, we might see a paracentesis done where we don't stick, but the doctor would insert a needle into the peritoneal cavity and aspirate out some fluid. This is free fluid that is in the belly. For folks that have chronic ascites, we can surgically insert a shunt too, and that will cause this fluid to be drained into the GI tract and then excreted. So there are several possibilities. The fluid removal there on the bottom with the paracentesis and the shunt are extreme cases. Most of the time we're going to see limited salt and diuretics and things like that. All right, let's talk a little bit about hepatic encephalopathy. This is a terminal being a key word, condition of liver failure. We are at the end of the line. The liver can no longer clear the ammonia that is in the body, so the ammonia levels will continue to rise. Ammonia will cross the blood-brain barrier. So when somebody's ammonia level is getting elevated, it does cross the blood-brain barrier and it will cause neurochanges or altered mental status, almost like the patient is drunk. Signs and symptoms, mention the neurochanges. There's also something called astrixis, and this is also known as flapping tremors. It is an involuntary muscle tremor. You might call it a jerking movement of the hand, almost like they're flapping their hands back and forth. Another classic symptom of hepatic encephalopathy is the fetor hepaticus. The body is trying to blow off these wastes that can't be metabolized and excreted, so the patient's breath will be foul, and that's called fetor hepaticus. They'll have bad breath, and it's secondary to liver failure. Treatment for these patients, obviously monitor LOC. their safety is going to be so important because they're going to be confused. The higher those ammonia levels get, the more confusion you're going to see. Protein restriction is a must. When proteins get broken down, ammonia is a byproduct. So what we don't want to happen is to increase their ammonia level. There is a drug you need to be very familiar with. It's called lactulose. We give the patients lactulose. They drink this. It binds to the ammonia and helps excrete it in the stool. But please understand, lactulose is just a supportive measure. It's not a fix for hepatic encephalopathy. It just helps decrease the symptoms. When considering the patient's nutritional therapy, patients with liver failure or cirrhosis are going to need increased calories, so 3,000 kilocalories per day. This will help prevent hypoglycemia. The reason hypoglycemia is so important is the majority of your glucose is stored in the liver as glycogen. And if your glycogen stores are gone, then you run the risk of being hypoglycemic. These calories will also help support the catabolism. They need high carbs, decreased fat, and their protein. I mentioned earlier with their protein levels, it will all be dictated based on how high is their ammonia level. If their ammonia level is super, super high, then no, they will not be allowed to take in protein. But if their ammonia levels are just barely elevated, well, then they'd be more likely to take in a protein meal. As far as the salt restriction goes, that's going to vary too. Do they have ascites? Because if they do, well, then we don't want the patient eating salt. If the patient does not have ascites, well, then we might allow a low salt diet for those patients. So with cirrhosis patients, we really have to look at things like their serum ammonia levels, and also, do they have edema or do they not? And this concludes part 5 of the lower GI lecture.